Good afternoon, everyone, and thank you for joining us for today's webinar as part of EUCOPE's Life Science Lectures. For those who don't know me, my name is Victor Martins. I'm the Government Affairs Director here at EUCOPE, and I'll be moderating today's discussion on making cross-border healthcare for ATMPs in rare diseases a reality. I'll leave the discussion of the details to our fantastic speakers that we've got with us today, but I did want to set the scene a little bit before we jump into the conversation. And I think the role of cross-border healthcare has always been important, and especially so in the context of rare diseases. And this is compounded, I think, in the conversation around ATMPs, which has been growing steadily with a number of clinical trials, submissions, and authorizations over the past year. And I think due to the infrastructure requirements that are needed to deliver these kind of therapies, the size of the patient population, cross-border healthcare typically is an interesting approach in that context. So, as you're undoubtedly aware, cross-border healthcare covers a whole host of different issues, from two routes at the EU level all the way down to national approaches as well. And it's in that context we've got our panel with us today of expert speakers to break this down and kind of explain a few of the challenges and hopefully some of the solutions in the context of cross-border healthcare as well. So with that little introduction, and with kind of that context in mind, we've got 6 speakers with us today, or 5 speakers, apologies, my counting isn't always on point, to talk us through what that looks like. And we'll start with a short presentation from our colleagues at HICT that pulled together a study exploring cross-border healthcare, and then we'll move over to the second half of today's webinar, where we'll be having our other speakers join us for a different panel conversation to discuss cross-border healthcare in the ATMP context from their perspective. So with that said, and again, I don't think anyone really wants to hear from me, let me hand over to Amber from HICT, who's going to talk us through the study and kind of what your initial reflections have been, and that will then be the basis for our panel discussion afterwards. So let me pull up the slides, Amber, and then I'll hand over to you.
Yes, thank you.
Give me just 1 second. No matter how often we do these things, it is always a challenge. So hopefully now everyone can see the presentation from Amber.
Yeah, I can see them. So I assume everyone else can too. Okay, thank you, Victor, for the introduction. So indeed, we did a study on cross-border healthcare for ATMPs, and you can immediately go to the next slide. So just want to mention then that the introduction that I will provide today is based on a full report that we've written. There's also a summary available, which is actually a poster presentation, and these two are also publicly available. So the context that we are looking today, and you can proceed to the next slide, is that in some cases it will be necessary for patients to travel abroad for ATMPs. This is because we look at complex treatments, so highly specialized care, even infrastructure maybe, and we're looking at a very small number of patients. So we're talking about ultra-rare diseases, where there would be a limited number of treatment centers. Let's consider Europe here. So there will not be a treatment center in every European country available, and it will be necessary to cross borders to have access. And then if you enter, we want to mention that there are already some complexities related to the context of ATMP treatment and ultra-rare diseases. We want to emphasize that we will look at the cross-border element here because that on its own raises specific concerns. Next slide. the scope of the report that we made is that we looked at reimbursed products. So products that are reimbursed also in the home country, but it's not available. So we look at ATMPs that have successfully gone through the national reimbursement procedure, but the treatment, it's not feasible for the treatment to be available in the home country. So in legislative terms, we're talking about planned cross-border healthcare. This is because we want to exclude discussions, equally relevant discussions on early access, on fast access. We just look at what if the product is in the national basket of care, but it's not available in the country. So we know, for example, that patients with rare diseases also travel for experimental treatment. Again, very relevant discussion, but out of scope in this discussion. Okay, next. And we think that without any actions taken, there will be many issues that will still hamper access to the ATMP treatment if it needs to be delivered in another country. We have separated this in 4 categories. So we see issues related to the clinical journey, the patient journey. Then we see issues related to financing and coverage. Third are issues related to the authorization. And then fourth, we see issues related to data and data transfers. And if you press enter, then we will go through these issues. And again, I want to emphasize there are already issues that are related to ATMP treatment for ultra-rare diseases. And then on top of that, and we clearly make a distinction there, you have issues related to the cross-border elements. So on the next slide, we first look at the issues related to the patient journey. We know that the diagnostic pathway is already very challenging in this context because of the rarity of the disease. And most likely there will also be different specialists and hospitals involved already. You can have an expert center providing treatment, and maybe when the patient is stable, then follow-up can happen in a peripheral center. If you then add the cross-border aspect on top of it, and if you press enter, yes, then you see here that if the entire treatment trajectory is not clear upfront, there can already be issues there if everything happens within the home country. But in a cross-border context, there will be more significant consequences. A patient might need to travel again. The follow-up might be inaccurate, etc. And also there is by default one extra partner involved here, namely the treatment center abroad. So this makes the clinical responsibilities even more complex. So you could say the entire treatment is provided in the treatment center abroad, but that is just not likely or desirable. Because of the long-term follow-up, you cannot keep the patients that long abroad. This would also limit transfer of knowledge. So the centers, the national centers, will not gain additional knowledge on the treatment and the disease, which kind of conflicts with the idea of, for example, the ERNs. So it's most realistic that the treatment centers abroad only provide the aspects of care that cannot be provided in the home country. But then we believe that clinical responsibilities could be unclear and even more unclear than in a national context. Then second, on the next slide, we look at issues related to finance and coverage. In this kind of products, there will probably be uncertainty about this kind of treatments, and that is generally handled in a contract between payer and manufacturer, so the managed entry agreement. If we then look to the cross-border aspects adding to this, so if you press enter, then you see different issues arising here. So first, there can be a difference in the actual price. So remember, indeed, the product is reimbursed in the home country, but it's not available. And it also has its price, approved list price in the guest country. So if there are differences there, this can create already a discussion on who will cover that difference. There might be confidential price agreements within the managed entry agreement, maybe hospital discounts, although we believe that's not often allowed, depending on the jurisdiction. Next to the differences in additional price, there can be differences in VAT rates. So the VAT rates, they differ between countries, they can differ between public and private hospitals, etc. Also, and that's more related to coverage, it's if you would, for example, use the directive, then prepayment for the patient itself would be required, which the products that we're talking about here, that's not feasible for most of the patients, and it's definitely not equitable if that would be the case. And then in general, I already mentioned, but there might be some difficulties in executing the managed entry agreement because not all partners involved are aware of all the characteristics and all the details of the managed entry agreement. So for example, a risk of double compensations, or some difficulties to execute the managed entry agreement if there is no revenue in the home country because the patient is treated abroad. Then on the next slide, we have our third category, and that's where we're talking about the authorization issues. So we're looking at products where a prior authorization will be required, because we're talking about orphan drugs, quite expensive drugs. So it will always be necessary to assess if the patient fulfills the national reimbursement criteria. On top of that, if you want to travel abroad, so if you enter, then you also need an authorization for traveling abroad, so for the planned cross-border healthcare. And there we see that these authorization procedures, they're not developed to serve this particular context of ultra-rare diseases. So it's not always clear what needs to be in those requests. So there's also a risk of inconsistent decisions when these decisions would be made by separate entities. So if you would have a decentralized system, and indeed a lack of clear guidelines, what needs to be in these requests. Also, you often need to do separate requests for different aspects of care. For example, hospital versus ambulant, also travel compensations. So again, if you would forget one, or if it's unclear what you need to do upfront, then this again can have very large consequences. Third, we see that for these authorizations, the patients, they are themselves obliged to initiate and follow up this request. For some patients, this can definitely be okay and not a problem, but this again can induce delays when, for example, something is lacking from the dossier, then the patient kind of becomes a middleman between the treating physicians and the decision maker, for example, the health insurer. So all this together we know that in this context, there can already be delays, for example, in the diagnosis. And this is the point where further delays can be induced, and worst case, this could mean that patients are no longer eligible for the ATMP treatment. And then last issues on the next slide are issues related to data and data transfers. It can already be the case if there would be an expert center and a peripheral center, that there needs to be data transfer between them. And there might also be data collection needed for the managed entry agreement. And it goes without saying that the cross-border aspect adds complexity here too. Yes, next slide. Yeah, you can go to the next slide. So if we look at all these different issues, we developed a workflow, a roadmap, what's in a name, where there would be different steps taken with the aim of covering all these different issues. And I will go through them step by step. So on the next slide, we will start with defining the treatment pathway. You can already go to the next slide. So we developed a generic pathway of an ATMP, and it would be important that this generic pathway would be further specified for each individual ATMP. Because yes, these are often one-off treatments, but these one-off treatments, they also require pre and post care. So it should be very clear what needs to happen. And I want to emphasize that with any procedure that is performed on a patient, there are complications or adverse events that can occur. So here, it's also important that this is prepared as much as possible, even on these events that can or cannot happen. Next slide. If you know what are the different steps that need to happen, you can look and you can establish for which steps it is absolutely necessary that the patient goes abroad. So it would be required that you do this for each step separately. And important, this can also change over time. I can imagine if there's a new treatment that there is more that will be happened in the treatment center abroad. And over time, there can be some responsibilities transferred to an expert center in the home country. So again, this way encouraging transfer of knowledge. Once you have decided when what needs to happen where, you can define all the different responsibilities and avoid that there are unclarities there. We already discussed a lot of them. So you have clinical responsibilities, knowing where responsibilities transfer. There can be responsibilities around the product itself. So, for example, ordering, transport, preparing the product. Pharmacovigilance, we also mentioned if there would be adverse events, etc. Communication is also an important one. For example, thinking about communication towards a patient. So there might be language barriers there, for example. How can these be tackled? And then also financially, we think that it can be relevant that there are agreements set up, agreements between treating hospitals, payers, manufacturers, to cover these kind of agreements and have everything clear. And then next slide. When this is all clear, you can select the most suitable route. And we identified 5 different routes. And on the next slide, I will not go through this into detail, but what I want to mention here is, so the routes, what we mean by routes is the different way to tackle reimbursement. So you could go via the S2 route, so via the regulation. There's also a European directive, the second one, on cross-border healthcare, where there could be some costs that are covered. It's also possible that there is a national fund that covers certain aspects of care. We also explored what we call the backpack method, and that idea would be there that the home country, so the expert center in the home country would order the product, and the product would be delivered in the treating hospital in the guest country. And then lastly, it's also possible that there is an agreement set up between the payer of the home country and specific hospitals. So as you can see here, not going into detail, but none of them are actually ideal. They both have pros and cons in this particular context of cross-border healthcare. And then next slide. if it's clear how the entire pathway looks like and via which legal route you would go, then you can define the optimal authorization path. So which authorization needs to happen when and where. We really think that it can help having a centralized decision-making body. It should be clear, it should be predictable what the throughput time of such an authorization process is. So, for example, by predefining maximal periods. And also, as I mentioned, that in this situation, the patient is responsible for initiating and following this up. I think having some guidelines and patient support here is crucial. And lastly, we also have the issues related to data that can be solved by setting up a proper data plan. So I think most important here is which information is required and needs to be collected, and who's involved, which stakeholders are involved, and what are their responsibilities. So on the next slide, you again have an entire overview of all these different steps, which I've went through step by step. We try to develop a framework that tackles all the different issues, and we really try to look at it as a whole. This is just a proposal, so we're very curious to hear from you, also from the panelists, what they think of this. And to close, we do want to mention on the next slide that there are further steps needed to bring this into practice. So there could be further iterations with stakeholders, as we're doing today, but also you could ask to patients how their first experiences are. Based on these discussions, it's maybe possible to zoom in on key building blocks, maybe the ones that are most considered most blocking, and really dive in there. Or it's also possible to develop some kind of toolkits for patients, for physicians, for decision makers, in order to bring this idea into practice. So to sum up on my next slide, so in some cases, it will be inevitable for patients to travel abroad to receive an ATMP treatment that is reimbursed in his or her own country, but not available. And this cross-border element will present its unique challenges on top of the challenges there are already in ATMP treatment for ultra-rare diseases. Without any actions taken, without any changes in the current system, we believe that there are various issues related to planned cross-border healthcare that will hamper patient access. So it would be key to create more transparency, more predictability to improve that patient access across national borders. And indeed, as I mentioned on the previous slide, further steps will be needed to bring this into practice. Okay, I will hand the word back to Victor.
Perfect. Thanks so much, Amber, for that presentation and trying to summarize a lot of content in a really short period of time. And again, I think it's a nice basis for us to start this conversation. I saw a few questions come in already from in the chat as well, and we'll be able to take those at the end. But I think at this point, I'd like to actually turn to our panel. And based on what Amber said, bring in our different speakers and have a bit of a conversation as to how each of you see the cross-border healthcare conversation, and really kind of from your 4 different perspectives. So with us today, we've got Matt Bowles-Johnson from Eurordis Rare Disease Europe, Dr. Maria Pia Cicalesi, which hopefully I pronounced correctly, from San Raffaele, Thomas Bowles from PTC Therapeutics, giving the industry perspective, and last but certainly not least, and I think someone that we all know, Yoda Cook, formerly CEO of Inami and currently there in a capacity as senior advisor as well. So really at this point, I kind of want to turn over to you 4 as really kind of the experts. And maybe starting with you, Matt. Amber, on a few occasions mentioned the importance of the involvement of patients, the challenges that the patient community faces in trying to get access to some of these therapies. So maybe you can start with you and kind of have you react a bit on what you heard from Amber and maybe touch on why cross-border access to innovative therapies is so important from the patient perspective.
Thanks, Victor. I wanted just to start off by, we all know rare diseases, the hallmark of rare diseases are they're complex, they're progressive, degenerative, they're disabling and frequently life-threatening conditions. And the problems with getting a diagnosis, the lack of available treatment. But really living with that as a reality, when that hits you and your family, you're given, your whole life changes. There's no available care in your country. There's no treatments available. It's quite a dark place. And then what advanced therapies, gene and cell therapies do for people in the rare disease communities, give them hope. It gives them a viable option that actually there's a treatment available which can be accessed. And that can really change people's lives, that these are potentially curative treatments. When that treatment is in another country, I mean, that's devastating. The barriers which we've just heard from Amber, it's a really messy pathway. The legislations don't fit together very well. So, we need to ensure there's greater equitable access across Europe. And even after the years we've had gene and cell therapies around, equitable access remains poor. And at the time of real vulnerability, a lot of treatments are only available at a very small window of time. And if you miss that window, you miss the chance of actually giving your child an opportunity of a life, really. So why is this important to our community? We have 95% of rare conditions without an active treatment. Gene and cell-based therapies or advanced therapies are offering that hope. And we need to really cut through the bureaucracy which is there. And we really need to, I think with a lot of conditions, they're actually more prevalent. So for your Zolgensma's, for SMA, treatment of SMA in each country is probably likely and possible, and the level of clinical expertise in those countries, because there's enough cases. But when we're talking about ultra rare diseases, these are people we are falling through the cracks of our system, and actually we need to support them, and not put the responsibility on families when they're vulnerable to have to navigate this complex system to access a curative treatment in another country. So I think for me, it's inconceivable, especially when we talk about ultra rare diseases, that all services and all treatments will be available in all countries, because size matters. We have to think on a European level, and I loved what Amber said about centralization. And I think the report you've done is great. But I think the thinking needs to be pushed a little bit further. We're at a point now on a European level where we're moving into joint clinical assessment for ATMPs next year. Bit of a scary time for everyone. But there's a willingness, to start working more at a European level. And we need to build on that. If we can attach to that an innovation fund at a European level to allow access for maybe 2 years for a new therapy for ultra rare conditions to put in place, then that gives a level of access and security to develop services and say, okay, well, we won't have a highly specialized service in each country, but let's have one in Milano and let's have one in Stockholm and have that on a European population. So I think centralization, I love it in the report, but I think we need to push that thinking more from nationally to a European level.
Perfect. Thanks, Matt. And some interesting ideas already there to kind of to get the ball rolling and kind of hear what might be interesting. Well, with that in mind as well, and again, we're talking about centralization. We've mentioned Milan already. So I want to use this then as an opportunity to move from the patient to the clinician's perspective, and hand over to you, Doctor, and kind of hear your perspectives from a practitioner perspective. You've done a lot of work in this space. You've treated quite a number of patients, but you've also seen these challenges firsthand from your perspective. So it'd be great to hear from you, Dr. Cicalese, what you see as kind of some of the challenges, barriers, and kind of what you thought of what some of the solutions were outlined by Amber in that report as well. So over to you, and let me know if you'd like me to share your slides at this point.
So hi everyone, and thanks. It's an honor to be here to highlight the crucial bottlenecks for patients and families in this very hard path. So I'm working in Milan, and I've been involved in the gene therapy field for 15 years now. And we have at our institution, as I will show you in a while, 2 approved medicinal products for 2 very devastating diseases as ADHD, that is, I think, the most terrible severe combined immune deficiency, and the metachromatic leukodystrophy, that is a very devastating neurological disorder. And so we are now in the field of ultra rare disease. We are going we are moving day by day to cryo products, fortunately, because this product should reach the patients in the home country, theoretically and ideally. But still, these are diseases that are very rare, very complicated, and the study of the disease in itself, as well as the treatment path and are often centralized. So the centers that are really devoted and dedicated to the story of the disease and that are approaching a real medicinal product are really few. And still we have some fresh product, as in case of Strinvelis, that are a short life product. So with the need for families to come to Milan, to come to the center, and not the opposite. But I was really aligned with Amber and with my colleague in figuring how devastating and time spending is the elaboration of a new diagnosis, and the approach to move with maybe more children to another country to spend months there, to just put your life and your baby's life into the hands of unknown physician, because you know that the alternative is the death of the baby, and you have just to cope with all these things, and to fight together with this, with the bureaucracy and with the systems that are really different still now in Europe. So I would stress that we need 3 things, I think. So first, homogeneity among Europe in just approaching, in agreeing, in supporting families with cross-border and by social security regulation, of course, because as Amber was mentioning, it's just unlikely to think about the directive for this kind of treatment with the need for patients to anticipate just a huge amount of money. So it's impossible. The quickness, okay, by the centers in just giving the green light and in just giving the okay to very life-threatening condition and to treatment that are just you can apply in a very short window of life, as you said. And then we need also an adequate information by national contact points that are still now bottlenecks because they are not aware, not well informed about the options, the center who is guesting the patient, so they are not helpful in just speeding up the process.
Perfect. Really helpful kind of opening there, and 3 very clear, I think, messages as well as to kind of how you see some of that moving forward. I want to pull in Yo at this point because I know you have to drop off at 2 o'clock, so won't be able to stay with us for the full session. So I do want to hear from your side as well, from a payer perspective. how you see some of these challenges and kind of some of the solutions, outlined by, we've got solutions from Amber at this point, from Mats, and from Dr. Chicalese as well. So I don't know if you have any thoughts to throw in at this point.
I think this is a great analysis, which is showing clearly that there is a need for a clear roadmap in order to fill the gaps which are for the moment clearly there. And scale matters. Someone has said it, I think it was Mats, scale matters. And of course, patients cannot in Europe, because we are looking from the European side, also when a patient cannot be the victim that they are living in a small country. In the European region of WHO, we have for the moment more than 13 countries with on average less than 2 million people. When you are a rare patient in these countries, it's a lottery, and you cannot expect that all the new requirements, technical requirements, are present in each country. This, I think we have to consider that when also with the European, from a European perspective. There are different reasons, I think, why these ATMPs are not reimbursed. There are financial reasons, and there you get another problem. Then when a country is deciding not to reimburse an ATMP, okay, the patient can difficult, and you are dividing the patients in the haves and the have-nots in money terms, then in monetary terms, because they cannot go abroad unless they are paying themselves for that, or based on an additional insurance eventually. And then you have the scientific view of that, and someone has already raised this issue also, that this joint clinical assessment can be, of course, fruitful. But nevertheless, I think we should be more ambitious. This study can offer practical solutions in the short term, but I think even in the short term we should stay ambitious to go to a more integrated European approach. I think when we look to the Enrico Letta report on the on the European policy of it's more than a market, he says. Europe should be considered as a place in which scale and cooperation between countries should be clearly on the table. And I think that should be one of the ambitions, to see, okay, what can be done on a European level, taking into account which can waive away the practicalities in which patients are confronted with, because we're going to have a struggle against bureaucracy, but let's try to homogenize and to have an integrated view on that. It will not be an easy thing, but nevertheless, I think there are solutions which could be clearly done. And for instance, the homogenization of the S2 authorizations, I think that's a clearly messy thing, in which we don't know on which basis all refusals are eventually taken into account. You see a lot of countries, including Belgium, in which ad hoc solutions are be found via a special fund or via special legislation even. I think we need an integrated framework in which this report can play an important role to foster also the possibility to go to find European solutions. It will not be easy, because we have to do with two instruments which are depending on two different and from the two different sources. One is from the social security perspective, the other one is from the health perspective and cross-border care. And probably this is a puzzle. We should, because in the one instrument, it was clearly pushed there by the European Parliament in 2011. The European reference networks can play a role. On the other hand, they are not involved in social security issues neither. And I think there is some gap and some puzzle work we have to do in order to streamline and to align the different issues together with better joint clinical assessment. I think that can be considered as a step forward. One recommendation also, I think it's useful to go and sit together with the European Health Insurance Associations, ESIP and AIM. Probably it's good to see also, to open their eyes and see, okay, what are the practical reasons between the organizations in their organization to give access to their to patients who are in need for these treatments. And of course, there will be the question of coordination of the treatment when it's only to give a technical procedure. You will have, of course, to create this referral pathway in which data are exchanged and which progress is monitored and so on. And I think that's important also to consider. But there are examples, I think, and you have also studied the Belgian case in which Belgium was not able to deliver treatments because the infrastructure was not there. Proton therapy, for instance, for children and brain tumors. Okay, there we have made agreements with hospitals. Know that 9 or more than 9 hospitals, university hospitals, are working now in a framework joined for ATMPs. This is an interesting exercise in which we should see, okay, they have also as a mission from the European Commission to bring to demonstrate which are the hurdles, not only on the scientific front, because what are you doing with a treatment when nobody can benefit of that? It cannot be stay on the shelf as far as there's sufficient evidence. The specific evidence delivered. And I think these are consortia in which it would be useful to have also discussions with, in order to prepare a technical document for the future European Commission to say, okay, here work can be done and delivered as soon as possible, knowing that the European Commission will also ask to the member states to draft a rare disease plan. Okay, rare disease plans, but also on the European level. I think not only member states, and it should be clear what that this team and this issue, this topic, should be part of it. I will leave it here. Thanks a lot.
Thanks so much. And I think you've touched on a whole host of different things. And I think I think I jotted down at least 5-6 different specific recommendations already, from writing technical recommendations all the way to, if I can be so bold as interpret what you said, potentially reopen 2 pieces of legislation to make sure the jigsaw fits better together. Well, with that, I want to turn over to our last speaker to kind of get us to give his initial reactions. Thomas, a lot's been thrown out already. JCA has been mentioned, I think, by almost everyone as well. And I know you've also got a particular interest in the backpack idea that Amber mentioned. So maybe just hand over to you, Thomas, to give your initial reflections as well from kind of your perspective and that of the industry as a whole.
Okay, yeah, thanks, Victor, and happy to be able to give some points from the industry perspective. Industry meaning the pharma industry that produces the cell and gene therapy that we're talking about. I mean, as a last speaker, you always run the risk of what can you add to what has been said before, right? Because I agree probably with a number of points. Maybe to underline a couple of things. First of all, I think indeed it cannot be emphasized enough that these ATMPs, the cell and gene therapies, are really transformative therapies, right? And it's really, if you see the impact that these therapies have on the life of patients, that's quite dramatic in a positive sense, right? Because of the nature of this technology and the fact that they really address the underlying causes of the disease rather than just treating symptoms, what we typically do. So that's important, and so therefore it is indeed important that all patients that are eligible for this kind of therapy should really have access to these therapies. And we shouldn't be making a distinction between those patients that live in a country, whether it's actually small or large. I don't think it's always small and large. If we're talking more about patients that live in a country where there is a specialized treatment center versus a countries that have not a specialized treatment centers, it is important, right? And I think the challenge that we have is that on the one hand, legislation that we're talking about the S2 route and the directive, and I'm sure in the report you can see the details. The challenge is, if you look at the numbers these legislation have, this was developed in between 2004 and 2011. So that's more than 10 years ago, right? Maybe 15 years ago. So we didn't even talk about these kind of novel technologies at all. So clearly that this legislation needs to be adapted, or is at least not fit for purpose. Because on the other end, if you look at the statistics, and I looked up a little bit, admittedly it's a bit old, but I see here, for example, in 2019, which, okay, it's 5 years ago, but still, I don't think it will today be much different. 290,890 patients received treatment outside their country. But the issue is, of course, this is more non-specialized care. So you have to think about hip replacements, knee operations, etc., which of course are also very important, but yeah, they are sort of qualified under non-specialized care. If you look at specialized care, so not even talking only about ATMPs, in 2019, only 23 patients received. So there's a huge difference between sort of patient that needs specialized care, probably a number of, rare disease patient, and the sort of like, can I call it, the more general population that has access to non-specialized care. So clearly for this kind of very specialized care with very highly innovative treatments like cell and gene therapies, we have some bottlenecks, and that clearly has been laid out by Amber in the report, etc. Also, just to emphasize, of course, is that not every cell and gene therapy needs to be treated in specialized treatment centers that are not there. We're talking here about a reasonably unique situation, but where indeed the technology is so specialized that you really have to administer this in very specialized treatment centers that are probably available only in a few countries. And as we know as well, despite the numbers that I mentioned, our healthcare systems are really organized across national lines, right? Health insurances, your whole healthcare system is based on a country. It's not really fluidly integrated. I think in terms of solutions, I think people, if after the presentation you could see sort of the options and the different solutions that needs further discussion between all of us, between, as you say, health insurers, industry, patients, authorities, etc. I think from an industry perspective, probably fairly agnostic. What would be the best solution, as long as it is, as was said before, as the system is more predictable, if it is consistent, that you know as a patient what the outcome of the process will be, that it is a reasonably light process, right? Because at the moment we know from case study that it is quite challenging for both physicians and patients to go through this whole administrative process. It should be a bit more lighter, and it should be sort of indeed transparent, right? What we clearly see that apart from that it is challenging to access this kind of healthcare, a large number of the population, including patients and physicians, don't even know that it exists, this kind of route. So we need to have a transparent, predictable, and consistent system in place, and that can be done through different routes, as was outlined in the Higgs report, and that requires further discussion between, as I said, between the different stakeholders that I mentioned. Thanks.
Thanks, Thomas. I think some interesting things that have been coming across that I kind of want to pull together is, I think the NCPs kind of not living maybe up to everything we expect from them. I think Thomas, the interesting perspective on the limited number of cases, and also I think some of the challenges around the transparency, practicality. I think, as you mentioned as well, the fact that there's not always a clear understanding as to how, for instance, the S2 route, and to put it in black and white, that's probably the most common route, I think, for some of these patients traveling between member states, is, so lack of clarity as to when those might be accepted, why they might be rejected, and how to use that, I think, is one of those other key challenges. Again, I just want to remind the colleagues as well listening in that if you do have any questions, do throw those into the Q&A. We'll pick those up toward the second half. But I want to go back to you, Matt, as well. I think you laid out a few initial ideas of how to address this. You picked up the centralization points, the innovation fund. But as kind of think the colleagues have rounded out the picture, I don't know if there's anything in particular that kind of you want to build on, or if there's anything really kind of from the challenges that some of the patients face, their care, their families and the care specifically, that Dr. Chiquilez mentioned, that Thomas pulled out there as well, that you might want to kind of build on.
I think the report very clearly states that the only real viable route is the S2 route. And I think Thomas's figures around the cross-border healthcare directive speak volumes. And the last report I read about the directive was, it was presented in a way that there's such a minimum amount of cross-border care being accessed. That was a good thing. It's not a good thing. These should be supporting people access care abroad when needed. And the need is very clear for people with a rare or ultra rare condition. We commented when the cross-border healthcare directive was being reviewed that actually we called for a special route or an exceptions clause being put in. And the feedback was for ATMPs. And the feedback was, well, they don't make legislation based on exception. Well, actually, that is a form of discrimination to a European population because it prevents them from accessing the care and support they need. Member states have a legal obligation to support or responsibility to meet the needs of their population, their health needs. And by not thinking about those exceptions and not making some adjustments to rectify that, I think is a failure in simple terms. So I think that if we can go back to, seeing how these two pieces of the puzzle fit together, I think the cross-border healthcare directive could have an exceptions clause in there for these cases to enable people to access. We talked about the need for, one of the challenges is around the routes is around prior approval and getting that in a timely way. The system is opaque. Who are the decision makers? Leaving that to a family to navigate, and San Raffaele is a prime example. Forgive me, you struggle to find who is it in Sweden, in northern Sweden, who makes this decision. I think that's an opportunity where the Commission can play a part. They can make it transparent on the Commission website. Who are the decision makers, either at a regional level or a national level, for people to get a decision in a timely way? I think that's an easy step which can be done, and it's in the gift, which without any changes to the legislation. For me, I think that we look at the ERNs, and it's mentioned a bit in the paper. But I think the ERNs, they have a legal, they're set up under the cross-border healthcare directive. Great. They're established now. Great. But what is their role and function in cross-border care? Let's formalize that. When there's a referral from France to Milan for Strimvelis, why can't it be an ERN which gives the second opinion in the org saying, yes, this is the right, clinically it's appropriate. This person fits into the eligibility, and this is an expensive treatment. They will get the best clinical outcomes from it at this point in time. Those are simple things which can be done now. But I think just going back to building on and maybe springboarding over the joint clinical assessment, I mentioned before about having a European fund, having a European fund like we have in Italy, which would give a two-year window to establish a service, enable access, and enable member states to set up cross-border pathways between Belgium and Germany, etc., and things settle down before the payments then get dissolved down at a national level. But let's go one step further. Let's start thinking about having European treatment centres, which can be like lighthouses for these ultra rare conditions. Let's centralise it a bit at a European level, the planning of these services. So member states go, okay, let's have for Strimvelis, an example, let's have one centre for the whole of Europe. But for another condition, it could be two. Let's think about where to build that and start doing. I think those things for me build on what the ERN started to do, which is a European health system, which is much needed. So I think those are some of the things which would unlock some of the bottlenecks which we hear and see, enable people to understand, you know, who can be referred and who signs the bill, remove bottlenecks around enabling the development of managed end-to agreements or pathways, and building those data pathways as well. So I think those are some examples for me where we can really move forward. And I love Joe using this report to now build a framework, a European framework. I love that, Joe. I think, you know, we need more of you in the world, Joe. So how do we do that? What's the next step in that?
Thanks so much, Matt. And again, I think a lot of really great ideas from the how do we implement what we have today without needing legislative change, all the way to kind of some of those more ambitious reach goals as well. And I think indeed looking at what can we do today, tomorrow, I think is essential, because I think indeed at the end of the day we are talking about some practical changes that could have very dramatic real life implications as well. You know, I know you need to jump off in about 4 minutes, and Matt pointed out that we need more of you in the world. So maybe we can give you 4 minutes to maybe kind of just reflect a bit on what you've heard as well, and maybe give us your last thoughts before we continue the conversation with the rest of the colleagues.
Thanks to give me this possibility. Okay, I think we should. And we should try to find a good use case, not a business case, but a use case, a patient case, in which it's clear that we should test all the elements which are at stake for patients. Then I'm not talking about the clinical assessment and so on, because that's different stuff. But once there is sufficient agreement about the added value of the treatment, I think it's important to see, okay, how can we fill the gaps in Europe, and how can we see, okay, and I think the patients' organization can play their role, and also the ERNs should play their role in this regard, to see, okay, we can improve the situation of these families, because it's not only the treatment, it's also the charges of family and the emotional consequences of being affronted with questions without response. I think that's also a very important thing. This one suggestion is, can we find a good use case in order to see and to test out the framework with some countries, which can prepare, in fact, the work for the European Union. It's still the member states who are steering the European Commission. I think it's important to create a kind of coalition of the willing, to see, okay, how can we prepare something very concrete together with patient organization, health insurers, treatment centers, evidence, to see, okay, what happens when we are doing nothing. We are leaving people behind, which is not in line with the European Pillar of Social Rights, which has been updated during the Belgian presidency. And I think we have to update some of this legislation now. I understand that regulating by exception, it's not the good principle, but nevertheless, the question is this an exception when there is high medical need? Then you have to do with public health needs and so on, and not only with exceptions. I think that's not the right answer to these issues. For me, the report which is on the table, I think, is a very elaborated report, which can be a format to discuss with other interested people, with this coalition of the willing, coming from the different side. And I'm totally agree with what Matt said with regard to the European reference network. It's not clear what is their ambition. Is it scientific? Is it only for referral of some information, or is it also exchange for patients? In fact, in this case, or in this discussion, there are three possibilities. You can the patient can move or travel. You can move the treatment. That's another thing, and for some treatments that's the case. But you can, the third option, I think that's the most preference. You can change the process and saying, okay, we have now some building blocks, but let's look where can we make the difference and change the process also, and do it all aligned when there is a joint clinical assessment. Let's end with some clear questions. When there is a joint clinical assessment which is saying, okay, this product or this treatment has added value, what are you going to do and say in your country where patients are living without not the technical requirement and not the skills of university hospitals in other countries? You have to find an answer. Science is for everybody the same. This added value is for everybody the same. And there's, of course, a question of money behind, always the case. But there are solutions by creating some solidarity funds on an international level and so on. Secondly, in this directive, cross-border directive, there's a huge contradiction. The European Parliament in 2011 has integrated these ERNs. But when you have not your ERN in your country, or when you have an ERN and people are receiving an advice from a university hospital that the treatment, for instance, with an ATMP would be beneficial. Okay, when it's not in your package, you have created false hope for this patient. Let's leave this contradiction out of this cross-border directive. This is not a question of management by exception. It's a question of good sense and common sense to do so. And of course, there are questions with regard to financial, and we should avoid free riding and so on. But nevertheless, when there is no sufficient option, we cannot create proton therapy centers all over in Europe. That's not possible. That's the reality, and we have to see why it's not useful, and because the European Union said, okay, you have to spend your money clever and smart with regard to health systems. You have not to create an exceptional treatment center for 2 patients a year. That's not a good use of money. Good use of money is cross-country collaboration, is working together, joining together, and that's Europe, and that should be the real phase of Europe.
Thanks, Joe. I think a clear message from your side. Maybe one quick question from the audience before you leave, and I think you might be the best place to answer this. And again, Amber, unless you've looked into this as well, but is cross-border healthcare directive possible in UK hospitals after Brexit? Asks Mark Domes.
I don't know, Amber. That's a case for you. No, I'm not sure to. And which British hospitals? Because that's another thing. In the NHS, you mentioned, yeah. I don't know if this case was looked after. I don't know.
It was a question for the audience. I don't know if anyone happens to have a direct answer. Oh, and there we go.
Chris is there. No, directives are not longer applicable.
There we go. A nice clear answer.
Yeah.
Can I just add to that?
Computer says no.
Yeah, very good job. So in our European Conference for Rare Diseases, we had a panel on European lighthouses, and we had a national commissioner from the UK who came over to talk about how they set up services, and they gave an example of I think it was surgery for fetal surgery for spina bifida. They had contracted that with Leuven Hospital. So Amber's example around this member states doing direct contracting with hospitals to meet the population needs. The UK is already doing that. So irrespective of S2 and the directive, I think that is, for me, an area of good practice. I mean, that's my old team. I used to work in the national commissioning team doing those services. So it's that level of thinking where nationally you think, we can't provide this locally, or it's better to be provided in another country because of safety reasons, or for clinical, it's better outcomes and it's more affordable. So I think that route of the report, Amber, I think we can really build on.
Yeah, yeah.
Perfect. And I see Chris is elaborated, so indeed, probably not on the S2 route. Sorry, but the S2 route does exist under the UK EU protocol. So there we go. We've got an answer there. Yo, I don't know if you've got a hand up.
Yes,
so I don't know.
yes. One complementary reaction. I think that's in taking contact with the joint for ATMP hospitals. I think it's also something which is an interesting way to see things and to see in which way contracts can be concluded with health insurers and specialized centers. Not all this. I don't know if Milano is taken part of this network, but nevertheless, let's give opportunities, because then you have also quality guarantees and so on. And I think it's important to not exclude this road and this way, this pathway neither. It's conventions with regard to health insurance hospitals, but in the broadest way to do so.
Perfect. Thanks so much. And again, I think we were talking about pulling in some examples and kind of looking at what this looks like in the real world. And Dr. Ciccadese, I think you've brought a few examples with you as well. Thanks, Yo. Thanks so much for making the time. So I don't know, again, I've got some slides from your side, which again, we can maybe spend a few minutes talking through if you think that'd be helpful. But I know that you can bring in a few real world examples as well, kind of from your experience.
Yeah. So no time for slides.
I can pull them up and we can quickly go through them, just so that you can kind of share some of your experience. So let me just quickly throw these up here.
So, okay, so we can go fast. I can indicate. Okay, my disclosure. But yeah, I think we can go into the core of the question. So just here, thank you. So sorry. So we, as I told you, we have experience with the 2 approved medicinal products, and I just want to stress that the Strimvelis for the treatment of ADA-SCID, it's a kind of old generation gene therapy product. So it's a retroviral driven gene therapy, and it's a fresh product, so only available at San Raffaele. I think the core of the question is that, again, we are in the ground of very rare diseases, and we have a number of variables, putting some obstacles for the availability of this advanced therapy product. And if we think about new generation product, we have a number of approved drugs also for, as for example, Libmeldi, but in the case of beta thalassemia, retroviral lentiviral gene therapy, for example, we know that it was ready to be used, but the negotiation path failed. So, and if we think that thalassemia is the less rare disease among the diseases for which ATMPs do exist today, we understand that we have a number of variables just putting obstacles to these new drugs. So I think the world is going to cryo product. For all the product, it will be difficult to have type 2 variations at EMA, for example, because again, just few patients treated and a lot of money and effort to be put to a change in manufacturing for these products. So I think centralization in some cases and for some diseases is still the key. So next slide, please. And so when we first approached the Strimvelis case, we made use of this toolbox that is designed for a legal framework of cross-border healthcare for patients and national contact points. Next slide. And we know, we talked a lot about this. We have two legal paths for this kind of treatment, with social security regulation, again, being the choice, definitely, for ultra-rare diseases for cost reasons. So, next. Yeah, next. And also the intra-country cross-regions treatment is also challenging. So for regionalized funding models in some countries that are just putting some difficulties in the path of reimburse. Next slide. Okay, so this is the experience with the stream valleys. And so just to tell you that we receive referral of patients from abroad, and we from very specialized immunological centers. So the patient is coming once the eligibility has already been declared. We do a part of the screening phase at our institution, but we already know that the patient is very likely suitable for gene therapy, and the patient is just staying at our institution for roughly 4 to 5 months for just screening, backup, and the treatment with a period of outpatient clinic follow-up. We really refer the patient after treatment to the home country center. We trust very much the referring physician, and we are in contact with all of them. And so we align the follow-up of the patient in Milan in line with the availability of S2, because in some cases, as I will show you, we had the S2 approved for treatment of the patient, but not for the follow-up, for example. Next slide. So in the Stream Valley's case, we had, we had to face the issue of the treatment costs, and I will show you which kind of costs are they in one second, and of the support of the family, that is an holistic support. So as I told you, family are coming, they are a diverse number of people, but for example, Middle East families, we really face huge families coming here, and we set also a Just Like Home program founded by Fondazione Teleton, which is just providing all the kind of support for this family, from psychologists to cultural mediators to volunteers to educators, to also financial support for the logistics and for traveling for selected patients and families who are in need. Next slide. So these are the costs I was mentioning. So for Stream Valleys, we have the clinical costs, including hospitalization, lab test, imaging, drug administration as inpatient or outpatient, and baseline and treatment follow-up, and then the cost of the drug in itself, so of the ATMP, and the traveling and lodging costs. Next. So, and this is our experience. So before commercialization of Stream Valleys, we treated as compassionate use or hospital exemption 7 patients from Belgium, UK, Switzerland, Ireland, Netherlands, and Spain, with S2 covering clinical costs and ATMP, but no other costs covered for families. And after commercialization, so once the license was up to GSK, then to Orchard, then back to Fondazione Teleton, because on early 2023, Orchard dismissed the portfolio of gene therapies for primary immune deficiencies. We treated 9 patients. So with beautiful experiences with some countries, and a little bit of resistance from some other countries. So we treated for patients from Germany, and the experience was very, very nice. We had some issues with France. We eventually treated one patient with very, very, very nice referring physician, but still bottlenecks for bureaucracy. The same for Sweden and the same for Belgium. So we were not able to treat the first patient from Belgium while we obtained the S2 for another patient, but just for the treatment, as I was telling you, and not for the follow-up. And then with Spain, and a very serious case was from Poland, in which neither the enzyme replacement therapy that is really life-saving for this patient was available. So the family had to fight against, to retrieve ERT and then to come for gene therapy, but they eventually obtained S2. And we treated with private funds also 7 patients, so 6 from Turkey and 1 from Qatar. Next. And this is nice because it's the first, I think, part of this very, very tricky path that we published on Nature Medicine together with the first real world experience of Strimvelis very recently. So we treated 8 European patients up to March 2023, so 5 non-European patients and 6 Italian patients. And please note that in the lack of funding, that was the first reason of lack of treatment in some patients. 4 of them were non-European, so coming from low-income countries. So we were not able to treat them for funding reason. Next. So this is interesting. You can pull the slide. Thank you. So we have these 3. Yeah, please pull the slide. Thank you. We have these 3 options. So the first, the orange, is the Italian SSN patient. So for the first 3 years, as you know, we had the centralized fund for innovative drugs by AIFA that founded Regione Lombardia for the treatment of the patient, which paid the hospital for the clinical costs and the ATMP supplier for the cost of the drug. Then after 3 years, this fund is expired for Strimvelis, so there is now the interregional funding path. So the same for S2, so patient. So the European country is just paying Regione Lombardia, the same, that is paying the hospital for the clinical costs and the ATMP supplier for the drug in just an identical way, while for private patients, the government or national funding or the insurance is paying directly the treatment center. Of course, we have a number of differences for private patients instead of Italian or S2 patients. So the payment will be upfront. The VAT will be 22% on the entire costs. And there is a payment for eventual complications that will be paid as for private prices, so it's much higher. So this option, I think, is useful, but just when all the other options are just not working. That's all. Next slide.
Can I just ask you to wrap this up so we can go to the other speakers? I think we've only got a few minutes left.
Sorry.
Can I ask if you wrap this up so that we can, because
we've
only got a few minutes left.
Yeah, so you can go on. Just okay, just to show you that for Libmelli, that is the gene therapy for metachromatic leukodystrophy, we have a cryo product, so it's a new generation product with several centers in Europe that are qualified. And in which price and reimbursement negotiation succeeded. Okay, next. Yeah, And we treated 4 patients with Libmeldi since the approval, 3 from Europe, Czech Republic and Slovakia, and 1 from Saudi Arabia as private patient. Next. Yeah, and the same path is working. So in conclusion, we have some inequities, as we said. So the cross-border directive is difficult to apply for the upfront payment. There is a different implementation or interpretation of social security regulation when ATMP is not included in the basket of care of the home country. There is a lack of mechanism to ensure funding across regions in regionalized countries, and the foreign intra-European patients can be potentially charged more than local in-country patients, and then the travel and accommodation costs are not covered. So potential solution, we should acknowledge the authorities and the referral in the home country of the advantages of this therapy should be authorized by all the countries, and yeah, it would be likely to be built a special fund at country or at European levels, and we really need also health technology assessment coordination activity that should be adapted to ATMP. So I just finished. I just want to thank in particular Michela Gabaldo, our alliance manager at that time, who really pioneered all the founding paths for Strimvelis and Libmeldi.
Perfect, thank you. And I saw you the slide on the national contact points as well, which again, I think has come through a few times as well in the discussion. So really helpful. And thanks for talking us through that. I think it's really helpful to try and put some of these concrete kind of examples of the story as well. Kind of like you said, let's try and work these out a bit more. So with that, I also now want to kind of bring you back into the conversation as well. I think we've kind of gone into kind of what some of the concrete challenges are, the pathways that need to be explored, kind of a call as well for collaboration between the different stakeholders and different communities. And I think that's happening quite a bit. But I think it's important also to remember kind of what some of the considerations and activities from the industry perspective are.
Yeah, thanks, Victor. Yeah, what I find very interesting also from the last presentation, but also what Matt has said before around the ERNs and Joe said, etc., is there seems to be at least a consensus between all the stakeholders, as I say, the physicians, the patients, the industry, the ex-payer, that this is something that needs to be solved, right? One way or another. And there's some creative ideas out there that I think are definitely worth exploring. And some of these ideas, like a fund or as in the HIC report, the back methods and so on, are very innovative, let's say. That's very new and require probably a more heavy lifting, including bringing in the lawyers and so on, because of these legal changes. But there are other elements that I thought we'll just need to review existing mechanisms, right? Matthew talked about the ERNs. I think there's indeed a very interesting element, and there's a lot of discussion, of course, at the moment overall about what should be the role of the ERNs. I think in general, the ERNs are seen as a huge success and being really important for the rare disease community in terms of their expertise and knowledge, etc. But indeed, can we expand their scope and go more into, giving advice and treatments and etc. Right? So those kind of existing infrastructures, whether it's an infrastructure like ERNs or legislation like the directive in the S2 social security route that need to be improved, we can discuss. I think where, I don't know, we as industry may be struggling a little bit, but maybe the others as well, is who can sort of advance this discussion. Is this something for the new European Commission? Because I know, of course, the European Commission is responsible for its European legislation, and they may say, look, this legislation is not perfect, but a lot of the challenges that you highlight sit maybe more in the countries, so maybe it's the member states who need to solve it. But I don't know what's Matt, for example, what you think, but I think it could be good if the European Commission plays a bit more of a leading role in bringing together the different stakeholders to take what is now put on the table, not only the HIC report, but other reports as well, to see this needs to be improved, right? And at least bring all the stakeholders together to see where we can do that. Because ultimately, our ultimate aim should be aligned, and that is that access to these therapies is important for patients independently where they live or whether they have coincidentally access to a specialized treatment center. So maybe something for, as I said, maybe for the Commission to at least create a sort of a forum to discuss this further and see what needs to be adapted.
Thanks, Thomas. I don't know, Matt or Dr. Chiesa, if you've got any responses there as to kind of a call for for a discussion with the Commission or kind of other ways to exchange. I see, Matt, you've got off mute already, so.
I think absolutely, we need leadership from the Commission on this. I think that's part of their remit, is to bring people together and to provide a platform for these types of discussions to continue. And we go back to the joint clinical assessment, which is coming up. So I think there's a natural, next step is to be, not just talking about implementing that for ATMPs next year, but what do we do thereafter? I think Joe highlights about Join for ATMP, San Raffaele, Teleton, and Eurodis are members of the consortium for Join for ATMP, and that's a 3-year project, which we're just in the first year, which will come out with recommendations, which we will house a lot of the solutions, which I think can be then under the Commission to implement. So I think we should use that route as well to progress this discussion as well. I wanted just to highlight about the whole premise of the ERNs. Now that they're set up, the focus is shifted from establishment to integration, and the thinking on integration is in how ERNs integrated to the national level to complement with national systems. But integration isn't solely a national issue. We have to think about integration of ERNs into a European system as well, and that thinking hasn't been taken forward yet. So I think we can use the joint action, Jardin, as a springboard to think about those European pathways and to start really raising some flags around what can the role of the ERNs be at a European level to support cross-border care as well. So I think there's a number of initiatives which are happening at the moment, strategic ones, but I think some leadership from the Commission, as Thomas highlighted, would, I think, be timely.
Perfect. Well, we're coming close to the end of the time we have together, which is 3 minutes left. So I kind of want to run through this in reverse, but start with you, Dr. Chiesa, to see kind of what your final thoughts might be, kind of any key messages you want to leave with the colleagues, and also kind of if there's any kind of, actually we've got some colleagues from the Commission in the chat as well, but if there's any final thoughts, you've got Dr. Chiesa, and then I'll run through everyone else as well.
So I really hope that we can proceed together, and we can simplify these very hard lives of patients and families. And I really think we need to empathize more and to work at very high level to find solutions. These are really poor families with very diseased babies. So we are moving to even more and more sophisticated therapies, but we have to keep alive the therapies we have already in Europe and make them available for the patients. And I think we really need to work together among stakeholders, because we have different perspective and we have different, let's say, knowledge, and we have to be present together and to put our brain together to this final aim.
Perfect. Thanks so much. I don't know. I'll give Matt and then Thomas, give you each 30 seconds maybe for your last any kind of closing thoughts. But I think it might be a bit challenging after what Dr. Chicalese just kind of put down in front of us. But Matt, any final thoughts or any final message you want to leave us with?
So 10 years ago, I started with Eurodis, and a lot of the stuff we were highlighting today about what we need to do at a European level, I thought was a natural thing, but we weren't ready for it then. So I think, 10 years on, a decade later, I think the European collaboration has been building, and I think we can really benefit from that now. So I think for me, I feel more optimistic that actually we can move this forward now because the time feels right. I just want to underscore the importance of the ERNs and really giving them real accountability in this system to give it a foundation. And I think by doing that, I think some of these discussions around the recommendations which we're doing will fall into place.
Perfect. And then Thomas, I don't know if there's any final thoughts to you as well.
I just agree, right? So I think that I would like to thank actually everybody for the discussion today, and in particular also Hict, Amber and colleagues for this report, because I think it serves as a good basis for further discussion. I think maybe the webinar today was very timely because we're entering a new EU political season as of after the holiday. So if EU institutions need any new ideas about what to tackle, then I think this is a good subject to put on the agenda.
Perfect. Well, thanks for that, Thomas, and stealing some of my closing remarks. But also, just want to thank I see Helen in the chat as well from the Commission, indeed indicating it's something that we all need to work towards. It's indeed not only for the Commission. I think that's probably one of the messages I think all colleagues on the line will agree with. But great as well to see what we can do together. Indeed, with a new Commission mandates, hopefully we can pick up some of these elements, make sure Project Jardin is implemented well, get some of this integrated into healthcare systems, and indeed see if we can build on this. We've had the system for a while. Let's continue to iterate, build, and I think as all four of the speakers said, there's things we can do without having to revolutionize the system. We can build on the existing system first, or in parallel. So a lot we can be doing there. So I want to thank all four of you for a really interesting discussion. I think, again, it looks like there's a lot of kind of consensus as to where we need to go. I think a lot of ambition, a lot of great ideas, and really a question of putting these into practice. And also big thanks to Amber and the whole Hict team for pulling together this report and kind of being the source and the catalyst for this conversation that indeed hopefully comes in at a incredibly timely moment in time. And with that, I just want to again thank all of you. Thank you all for joining us as well, the fantastic speakers. And I've got my closing statement somewhere, but I think the main thing I just want to say is thanks a lot. Hopefully we can all see you again soon. And for those of you based in Brussels, hopefully you can go outside really soon and enjoy the sunny weather we have before it leaves us. So with that, thanks so much, and hope to see you at the next one.
Thank you.
Everyone.
Bye.
Thank you.
Thank you.
Bye.
Bye.
Bye.